Good evening, everyone. At the outset, I would like to thank CCI for giving us this opportunity to have this unique topic today of webinar. We will be discussing about liquid biopsy in lung diseases. This is a very unusual, uncommon topic, never much discussed among pulmonologists, and I think it will give us an insight about something new which is happening in mainly in oncology. And today we will have two eminent speakers, Dr. Tejas Shah. He is a molecular pathologist from Pune, and Dr. Amit Bhatt. He is again another eminent medical and precision oncologist from Pune. Both of them will be having their presentations today. The first topic by Dr. Tejas Shah will be technical aspects of liquid biopsy, and he will give us about the insight about liquid biopsies. And followed by that, Dr. Amit Bhatt, Dr. Amit Bhatt, he will be discussing about liquid biopsy in medical oncology in 2024. So after these two lectures by our eminent speakers, we will be having a panel discussion. We have three panelists from across India. One is Dr. Shilpi Dosi. She is coming from Indore. She is a consultant histopathologist at Indore. And we have two pulmonologists with us, Dr. Anil Kancharla from Vijayawada and Dr. Moitreyee Kalita from Guwahati. So we'll be having a very nice discussion. That's what I hope today. And we'll take some good messages from this webinar. Now I ask my audiovisual team to please start the presentations for today.
Hello everyone, good evening. I'm Dr. Tejas. I'm heading, molecular diagnostics and clinical genomics department at Krishna Diagnostics. Basically, Krishna Diagnostics is based out of Pune. At onset, I would like to thank the office bearers of CCI to give me this opportunity to talk on liquid biopsy today. So I'll be talking today on liquid biopsy and its multimodal diagnostic tools utilization in clinical oncology. Coming back, what is liquid biopsy and where are its utilization? Apart from oncology, it is also used in infectious, in drug resistance understanding, in reproductive. We do NIPT, that is non-invasive prenatal testing. In inherited, we do whole exome or whole genome scanning, and immunology HLA typing. When any organ needs to be transplanted, HLA typing is must as per the policy. So all these things can be gained by just a small liquid biopsy sample. What is liquid biopsy? Liquid biopsy is nothing but a minimal invasive technique. It is the test that is used for any kind of sample which we get from either blood or CSF or urine or saliva to monitor any kind of a disease. It can be cancer or any infectious disease as well. Currently, we use liquid biopsies for NSCLCs, cancer type, breast cancer, colorectal, and prostate, citing its tumor shedding rate are higher, and we get desired CTC quantity in the bloodstream. Why liquid biopsy? Gold standard has always been a FFPE tissue block, but in of lately almost a decade and last 4-5 years, liquid biopsy also has got a momentum. Basically, our tumors are part of vasculogenic, network, right? So it is bound to happen that whatever apoptotic, necrotic secretions, residues or apoptotic cells are there, it is going to flow in your bloodstream, and this is where we catch them. And once we catch, we isolate different type of cellular matrix like CTCs. CTCs are nothing but circulating tumor cells, extracellular vesicles. We go for cell-free DNA. We go for cell-free TNA, that is total nucleic acid. We also goes for miRNAs, miRNAs. Nowadays, even miRNAs have been utilized as a prognostic marker for liver and lung cancer as well. And once we isolate them from the bloodstream, we next step is to isolate for certain nucleic acids to detect translocations, copy number variations, indels, epigenetic patterns, methylation patterns, and these all genomic alteration help us to understand how cancer is behaving in your body. What is the role of liquid biopsy in precision medicine? Basically, precision medicine helps us to target with the right treatment to the right patient and at the right time. Let's assume that this all 15 20 patients are positive for NSCLCs, but their genomic alterations, I would call it as genomic kundlis, are different, right? Hence we need to give them different therapeutics to have their better treatment regimens, and that's where we can unfold the utilization of liquid biopsies to understand the genomic kundli or genomic alteration in this particular patients. Need of precision medicine or personalized medicine NSCLCs. Yes, I personally believe NSCLCs and colorectal cancers have really evolved in last 10-15 years with good chemotherapy reagents or immunotherapy reagents. If you notice, in last almost 10 to 15 years, we have got 15 to 20 new chemotherapy reagents which are directly targeting different kind of genetic alterations or genetic mutations. Like for EGFR, there is gefitinib, or ALK is crizotinib. So all these are available, but for that we need to understand what genomic alterations or mutations are there in the body, and this can be obtained by either FFP block or liquid biopsy. And now liquid biopsies are gaining momentum in NSCLCs kind of a patients where to get tissues is really difficult. So how does liquid biopsy overweight the tissue biopsy? In liquid biopsy, it's very quick. We have to just prick the patient and take the peripheral blood in the straight tube. While in standard biopsy, at the time you have to go for intensive, procedure or CT guided procedure as well. And localized sampling of tissue is desired in standard biopsy. Here it's comprehensive tissue profile. In case it's a metastatic cancer from lung to colon or any other organ, because your bloodstream has all cell-free DNA or CTCs in that, we can get a comprehensive overview as to how the different genomic alterations are behaving. It's easily obtainable, minimal pain and risk, and best part is it's kind of very less non-invasive technique. So that's really good in terms of liquid biopsies. What are its clinical implications? It can be used as a prognostic marker. It can be used as a diagnostics. Let's consider prognostics. On your right hand side, it's a cell search panel where we just take a peripheral blood from the patient, and then we isolate the CTCs using some kind of a matrix. We enumerate that. We utilize certain, or we map them with different antibodies like EpCAM, cytokeratin, TAPI, CD45, and we understand how the CTCs are increasing or decreasing in your particular volume of blood. And then there is certain threshold about that. We say yes, it is increasing, and there has to be a change in regimen of that particular patient. So it acts as a prognosis. This same logic can be used for screening of particular cancer as well. In diagnostic, the same CTCs what are isolated can be tagged with different antibodies or IHC markers. Here we have tagged with pan-cytokeratin, the pore-like structure. These are nothing but positive. CTs are highly positive for pan-cytokeratin, and then we get an diagnostic conclusion of that particular cytomorphological analysis. In the third thing is therapeutics. The CTCs, once isolated, can be further isolated for DNA, RNA, or total nucleic acid. Then we impart them on either next generation sequencing or digital PCR. At the end of the day, it depends upon the physician's requirement or the clinical application. In this particular sample, almost this particular sequence or nucleotides were completely absent. We call it as deletion of that particular DNA matrix. And once this gets detected, we understand how that particular patient is going to behave for particular chemotherapy or immunotherapy reagent. So this is must. Last but not least is response to immunotherapy. PDL1 markers help us to understand whether that patient needs to be given immunotherapy or not, right? So once CTCs are isolated, we again tag them with different antibodies to understand whether they are CTC PDL1 positive or CTC PDL1 negative. These are few clinical implications. Apart from that, this can be also utilized for MRDs, minimal residual disease kind of a thing. So, what are the molecular diagnostic tools to, utilize the liquid biopsies, be it CTC, cell-free DNA, ctDNA, circulating tumor DNA? Apparently, we mainly focus on digital PCR, qPCR, and NGS. NGS is next generation sequencing, qPCR is real-time PCR, and DD is either digital PCR or droplet PCR. Okay, so depending upon the endpoint application, and what we have extracted, we decide whether we should go on digital PCR or NGS. NGS is used for, if you want to study, anything more than 5, 10, 50, 500 genes, we go for next generation sequencing. But if you want to just study, KRAS, NRAS, or single EGFR gene, or multiplexing of 2 or 3 genes, we'll go for digital PCR. Digital PCR is, third generation PCR, which has got better sensitivity, specificity than real time PCR, and we can get a high sensitivity of 0.1% allelic frequency. So that's the plus point. And anything, we get gray zone allelic frequency, or if any orthogonal testing is required in terms of next generation sequencing, the same gene is again studied on digital PCR, and then we decide whether to give that, in the report as a pathogenic or non-pathogenic. So yes, digital PCR can be used as a diagnostic as well as an orthogonal testing tool. As I told, in last couple of years, liquid biopsies have started gaining momentum. But yeah, there are certain challenges and future perspective related to it. In terms of challenges, recovery of large amount of analytical sample from liquid biopsy is must. Usually, we require approximately 10 to 20 ml of peripheral blood to give us certain quantity of DNA, RNA, which can be used for NGS or digital PCR. At times, it really becomes tricky to get that particular circulating tumor cells or cell-free DNA if patient has been on long chemotherapy cycle. So it's really tricky at this stage. The second thing is RNA molecules are very labile. Directly isolating RNA or circulating RNA from the peripheral blood is really really difficult, and we don't get certain amount or nanogram per microliter to be utilized for again any molecular technique. And at times, yes, we do get false negative results as well. The third and important thing is variability of assay platform and difficulty in reproducibility of data. So if you study digital PCR or flow cytometry or ARMS PCR, the CTC's proportionate might get varied, and we need to standardize this. And still, it is under certain clinical trials. This validation is thoroughly ongoing, and we might expect this data by end of 2025. The future perspectives are innovative multiplexing digital panels are required. Right now, we are doing multiplexing with RUO kits. They are not CEIVD approved ones, but yeah, we do require CEIVD and 4 or 5 genes multiplexing panel so that we can give results within 24-48 hours. That's one of the future perspective. The second is advanced genomic approach that have higher sensitivity to identify mutations. So your data of mutations in cell-free, as well as if you have got a tissue block of safe patient, it should overlap, right, in terms of allelic frequency and in terms of different genetic mutations also. So this particular, standardization and optimization is still required, and multiple big labs across globe are working on that. And introduction of low-cost biotechnology or bioinformatics tools are also required. Right now, if panel cost X rupees, the analysis software is also costing us X. So it's ultimately 2X burden on the patient or clinical utilization. So we require a new bioinformatics tool which can subsequently decrease the analysis cost, and thereby commercial burden gets decreased on the patient as well. So right now, around 4 to 5 panels are available pertaining to NSCLCs or lung cancer panels. One is digital PCR-based EGFR monitoring and drug resistance panel. That is around 48 to 72 hours. It's very simple. First day, it goes in the extraction of liquid biopsy, then cell-free DNA from a particular liquid biopsy sample, and the next day we plan digital PCR. In this particular panel, we take consideration of driver mutations, drug resistance, and low frequency EGFR mutations. So the doctor understand whether he should continue with the same TKI, tyrosine kinase inhibitors, as a regimen, or he needs to shift to first or second or third generation TKIs. The second is Christian Comprehensive Panel, which is of almost 500 genes. 160 to 180 genes are overlapping with pan cancer, hotspot DNA, RNA genes. Plus, it covers MSI, TMB, HRR, and it also gives you the genomic instability matrix. That's the plus point when you work with comprehensive panel. Third but not least is the precision assay. It is CEIVD, first of its kind CEIVD kit, which is 50 gene panel utilizing both copy number variations, DNA DNA plus RNA. The same panel can be utilized for liquid biopsies also. So they both are CE-IVD. And for smaller panel, we do have 12 gene lung cancer panel, which covers ALK, RET, ROS, NTRK, fusions, MET, Fortin, SCAPE, ERBB2. So this panel, if patient is poorer and he cannot opt for multiple, or the bigger panels, at least this can help him to figure out or chalk out for the physician as to what is going wrong in that tumor or tumor heterogeneity. So this is how the typical report format looks of NGS. These are demographic data of that particular patient, and then there is a clinical history. If anything is positive, if there is some genomic alterations, the red pop-up will be there. This is a summary table. The mutations what have come down to be positive, POL, TP53, RAD54, whatever has come down positive, it's over here. Gives you a TMB score, MSI score as well. So this is for comprehensive assay. Had that this been a precision assay, we would have only got the alterations in DNA as well as RNA. Then on the next page, it's segregation of variant and tier classification as well. And just below that, in case there are suggestive relevant therapies, we also give that. So here it was olaparib, and it's already mentioned in the report. So take home message here is, with high throughput, molecular techniques like NGS, next generation sequencing, we can work with low input of DNA and RNA. If I've just got a small piece of tissue or very less CTC, circulating tumor cells, which I extract from the liquid biopsy, the low DNA, RNA will give me certain kind of genomic alteration. And here something is better than nothing. Rather, we don't know any alteration and we are just bombarding with any kind of a chemotherapy. At least in lung cancer patient, it is gonna be a dreadful thing. With over a period of years with its utilization, it has been cost effective, and it's high throughput. We can go for comprehensive panels like exome and MSI TMB panels as well. The add-on branches of liquid biopsy, where with very less minimal invasive procedure, if I just get a plasma or the blood, peripheral blood in the stek tube, we can isolate all the DNA, RNA, CTCs, EVs, everything, and we can go for comprehensive genomic profiling. The plus point of liquid biopsy is also, the dynamic monitoring. Once tissue is extracted, the tumor and heterogeneity monitoring is stopped there and there. But here, with different chemotherapies, the resistance, if there is tumor heterogeneity for any particular cancer disease, we can monitor it through liquid biopsy. So that's the best part and beauty of the liquid biopsy. So key points for decision makers: cancer is a disease of genome, and thus it is reasonable that treatment strategies should be based on genomic changes using certain molecular techniques. Liquid biopsy is a solid non-invasive tool in precision oncology. In localized cancer, LB can serve as tool to detect MRDs. In metastatic setting, LBs can detect tumor response as well as the resistance mechanism, as I talked about EGFR TKI's resistance mechanism. The number of different molecular alterations to be tested is expected to grow in the near future, along with the potential savings generated by the molecular-based techniques. As the technology, as the utilization of liquid biopsy is evolving, price is coming down, and maximum oncophysicians have started opting for genomic, reports or genomic kundlis while treating their physicians. So this was, something utilization of clinical utility of liquid biopsy in oncology. In next 2 to 3 minutes, I would also like to highlight on, NGS as a tool to eliminate tuberculosis, because I understand maximum population over here is our pulmonologists or chest physicians. So India accounts for 27% of the global burden in the TB, and maximum helm over here is, XDR or the antibiotic resistance when they acquired during the TB, disease as such. So in background, Indian TB report was released by 2022 by Ministry of Health and Family Welfare, and in this, I've taken a small snippet. They already mentioned about next generation sequencing. And here they have highlighted the objective is to utilize NGS using Minion. Minion is one of the principal while utilization of NGS for drug resistance prediction of first, second line, and newer drugs. So somewhere ministry is saying we should utilize NGS for understanding understanding the XDR or antibiotic resistance pattern in particular TB patients. Right now, available diagnostic tests are smear microscopy, what we call as Zn staining. Then there are certain culture techniques. Culture techniques will give us all 14 15 antibiotic spectrum, but it will take its with 45 to 60 days of tat, okay, which is really wrong. Then third is CBNAT, or we call it as Gene Expert. There are two kind of cartridges. One gives you only REF-INH, and other gives you second line, in antibiotic resistance. If we go for Gene Expert, the third is line probe assay. The disadvantage with LPA is, even though it has got a short duration, you have to culture and then isolate DNA, RNA, DNA particularly from that culture, and go for line probe assay. But the NGS technology and the panel what we have developed is Christian TB targeted panel. Here we don't require any culture. All the 13 WHO drugs are planned out in this panel, and you get results within 15 to 21 days. The TAT is bound to get reduced as we get more and more load of the samples, but right now it's 15 to 21 days, and we target to get down this stat approximately 10 to 12 days in coming couple of months as well. So this is how the NGS based drug resistance profiling report looks like. Something which is in green means that particular drug has sensitive nature. Something which is red is that particular patient is resistant to that particular drug. Something which is in pink is there is some amino acid change pertaining to that particular SNP, single nucleotide polymorphism, and hence this particular drug lies into gray zone. So be away from it tentatively, but you can always focus on sensitive drugs. So this is how NGS report looks like for drug resistant panel, and it surely helps all the chest physicians to monitor drug resistance and prescribe appropriate medications. uh, so that's it from my side. Thank you. These are my connects. If anything required or any help required from my side, I'll be always available for you. Thank you very much.
A very good evening, everyone. At the onset, let me thank Chess Council of India Office Bearers for allowing me to present on this prestigious platform. Thank you, moderator, and a special thanks to Dr. Nitin Abhyankar, sir, for having me here to talk about liquid biopsy and lung cancer. Let me just share my slides. So we are going to talk about basically lung cancer. I am a medical oncologist specializing in molecular oncology, and hence I would like to talk specifically about how liquid biopsy is utilized today, how we do it at bedside, and what are the various outcomes. So what has changed in lung cancer as of today? Basically, everything has changed. There are newer methods of diagnosis, there are newer methods of treatment, and most importantly, there are newer drugs with better efficacy and minimal side effects. We'll talk about all this in detail. What was that old paradigm where we were using at the diagnosis? We used to choose the best drug as per the guidelines available to us and then treat the patient. At disease progression, we used to use the next drug which is available in the guideline. So select drug and switch drug was the old paradigm. And this used to continue until there is florid disease progression or the patient is no longer fit enough to tolerate medical care. So this has been completely replaced by the new paradigm. What we are doing together is at the diagnosis, we are trying to choose the right drug. What is the right drug for the patient? The drug which is going to give us the best effect. And then once we choose the right drug, we can give good longevity to the patient. How do we do this? This is called as personalized cancer medicine. We are looking at better targeting and individualized approaches. So how do we target these is now we recognize lung cancer is no longer black and white or gray. There are a lot many colors and flavors, and there are different targets for each color. So this is where the new customized tailor fit and need for personalized therapy comes in. Each patient is different, every cancer is different, and every patient responds differently to therapy. This is one thing that we have to accept and understand. This is the first take-home message, that each patient is different. So all the patients with the same diagnosis, what we are doing as of today, we are having a lot of benefit, but at the risk of huge toxicities. What we don't want to do is we don't want drugs which have no benefit and only toxicity is there. We don't want placebo drugs where there is no benefit and no toxicity. And finally, this is what we intend to achieve, and actually what we are achieving today. We just want benefit with no or minimal toxicity. So this is where we call the targeted therapy. We are looking at targets. This is a lot of target therapy has been all over the news for almost every malignancy. Lung cancer is no different. What are basically targets? Targets are gateways on the cancer cell. If we can identify the gateway on the cancer cell, we can identify a drug which can go through the gateway, and here we can get really good responses. Now, if these gateways are specific to the cancer cells and not present on normal cells, then we are looking at only benefit because the cancer cell is going to die, and there is no toxicity because normal cell that these drugs won't act on. Looking at malignancy, let us just focus on a small part, adenocarcinoma. It's insufficient. The time is insufficient to talk about all the cancers in detail, but let me just give an overview. No longer it suffices saying that it is lung adenocarcinoma. We have to talk about various molecular diagnosis. This is a must. And you can look in the brackets, there are a huge number of drugs which have been approved by US FDA for each and every target. So this is a must in today's diagnosis. Merely saying that we are dealing with adenocarcinoma is no longer sufficient. And you can look at the response rates in the brackets. Just to put it in perspective, the response rates to chemotherapy were somewhere around 30 to 40%. And now we have drugs where response rate are 80 and 90%, as high as that. So targeted and molecular therapy has really changed. How do we diagnose? This is by molecular testing. These all molecular diagnosis. And this is what we look at. And actually, the computerized technology has helped us to look at this. We look at more hundreds of targets with thousands of interactions between them. And we can understand which is the most important target or which is the most important gateway. Though this diagram looks very difficult, this is what we are doing now in routine practice. So there has been talk about liquid biopsy and invasive biopsy. We have the basic concepts now after Dr. Tejas Shah's talk. We are not trying to push or compare liquid biopsy versus invasive biopsy, as I would talk in my next slides. How we can utilize the best of both in our clinical practice is the bone of contention today. Liquid biopsy, we talked about a lot of liquid biopsy methods. We use molecular assays for early detection, monitoring the resistant mechanisms. Now, what we are looking at mainly is the cell-free DNA or circulating tumor-free DNA, ctDNA, what we call this. Now, tissue is an issue. We have been crying this same story for a long time. In NSCLC patients, significant proportion fail to undergo tissue NGS, that molecular diagnosis, because tissue biopsy, the quantity is not sufficient or patient refuses to do biopsy. Very, very common. Again, the NGS reports takes around 4 weeks from the time to report, the tissue report. So this is where a liquid biopsy comes in. This is the clinical trial data where you can see that there is a median delay of almost 2 to 3 weeks getting the NGS report out of a tissue biopsy. Does it really affect in practice? It makes a huge difference. And how does liquid biopsy change this? If you do a liquid biopsy earlier, the median time to treatment reduces by half. Median time to targeted therapy again reduces by half, the group B. And the group C, where time to treatment for immunotherapy also reduces by half. So performing a liquid NGS as an initial approach can shorten the interval between diagnosis and anti-cancer treatment and improve survival in patients. So look at the guidelines. This is NCCN. This is the most common guidelines followed by oncologists. And now even in the guidelines, the NCCN says that if an assay has a technical failure related to insufficient quantity, then alternative tissue might be warranted. And the tissue testing by using alternative testing by using peripheral blood, which is either cell-free or circulating tumor DNA, can be utilized in conjunction with tissue-based testing. So these have NCCN for the first time in 2023 have recommended simultaneous concurrent testing of liquid and tissue biopsy. The first commonest question that comes into mind is, are both comparable? Is the tissue better than the liquid biopsy? Now, this is the complete study comparison of matched plasma versus tissue, more than 7,000 consecutive lung cancer non-small cell cases. And if you can look at the figures at the bottom, the concordance is pretty acceptable, almost 100% in most of the diagnosis. The tissue versus liquid CGP, comprehensive genomic profile, the concordance is pretty good. Now, the International Association for Study of Lung Cancer, they have taken it further, and they have asked that instead of sequential approach, you might also do a plasma first approach where if the tissue sample is unavailable or patient has refused, you can straight away go for a plasma first approach or a complementary approach where you're doing both simultaneously. How does that help? In clinical practice, if you look at the two circles, the 48% intersecting, this is what tissue and liquid biopsy both pick up. But if you are doing liquid biopsy in additional, you have 27% more molecular pickups, and if you're doing tissue, you have 21% more molecular pickups. So what will happen if you are doing both combined? So this is a data. If you are doing only tissue NGS, you detect almost 21% of the mutations. If you're doing only plasma NGS, you do 29% of the mutations. And if you're doing both combined, a concurrent tissue plus plasma approach, you are picking 15% more mutations as compared to what tissue biopsy alone. So more the mutations, the more difference it is going to make for the patient's life. I want to come to that later. Molecular diagnosis is not a new thing or something that is coming up in the recent past. This is what we had published in 2003. I was the first author. This is about EGFR and tissue diagnosis. This is one of the first papers from the country, from CMC Vellore, where we talked about prevalence of the EGFR mutational status in our lung cancer patients. And this is how EGFR has changed. We have seen a paradigm change in the responses of EGFR. It not only decreases the uptake of cancer, but it gives a meaningful clinical response, clinical improvement in the quality of life. The edema around it, as you can see in the pictures, the edema around the lung cancer is decreased, and the lung tissue repair is much better. Patients do significantly best as compared to the quality of life. Again, looking at the responses within a couple of months, you can see these two recent scans. The uptake on the lung cancer has gone down, the pleural effusion has gone down, the lung healing has occurred very nicely in the bottom picture. So this is how an EGFR mutation therapy really helps. I'm going to come about that in detail. We have published again data about tumor mutational burden. This is again based on the biopsy. What is tumor mutational burden? You look at amount of tumor mutations and try to classify it as high or low. Those with high tumor mutational burdens, this is in general for solid tumors. We had published this in the World Conference of Lung Cancer as well. And those who have high tumor mutational burden, immunotherapy can be used. So this is a pan-India data collection, and this is what we had shown that yes, this is very prevalent. We do this in our country as well. A word about circulating tumor DNAs, how this is not only for the diagnosis, the liquid biopsy. A liquid biopsy can be used for monitoring the patients. Let us look at this picture. This is a patient of EGFR mutant, and we were following up serially with a liquid biopsy. We could see that the mutant frequency, the allele frequency, the mutations have gone up significantly in a matter of a few months. And then we scanned him. The patient was asymptomatic, but we could definitely see there is increase in the uptake in the primary lung tumor. There is increasing in the effusion as well, and increase in the bony lesions as well. So this is how we pick up the asymptomatic lung cancer early. The earlier you pick up, the faster you can treat those patients and give them a good quality of life. So if you wait for symptoms, many a times the symptoms are so worse that patient might not be fit for treatment. So this is another aspect where liquid biopsy is changing treatment paradigms. The future of lung cancer therapy, as I said, liquid biopsy is not something of the future. It is what we are doing today. Again, another public pan-India collaboration, published data where we are talking about beyond EGFR and ALK treatments. So this is how we are looking at. This is a patient who was on treatment. There was resistance in the treatment. So we did a liquid biopsy, looked at various targets, and there were some targets which are there. How does it help us? It helps us in choosing the right drug for the patient. As I said, we have to use a drug with maximum benefit and minimal toxicity. So in a resistant case where you do a liquid biopsy must help us to give you treatment options and subsequently those pathways which we have picked up, we can use a drug and the patient will respond. As you see in this patient, such a big tumor which was responding, and a virtually clear scan at the end of the day. Now, this is the patient, another interesting case. Now, in practice, many times we come across patients who the relatives or the patient refuses because of the age to undergo a conventional tissue biopsy, or patient has undergone complications. Let me come to this patient. A 75-year-old male had bilateral lung nodules, mediastinal nodes, and a left iliac lytic region. Now, this was obviously carcinoma, but short of a tissue biopsy, we would never diagnose this patient. So how does liquid biopsy and the patient and the relatives categorically refuse to have any invasive procedure? So this is where liquid biopsy again comes into picture, where we can try to pick up circulating tumor DNAs, the bottom interpretation summary. So we look at specific targets, says that there are circulating tumor cells. Hence, we can identify that their patient at least has malignancy. So we have the basic diagnosis. Now, if the circulating tumor cells are sufficient in number, there are a lot of mutations which can be done, or IHCs which can be done. I'll come to that in a bit. So this patient, based on that liquid biopsy, which started him on oral tablets, and the response was there. So again, this is where things are changing. You look at again the picture, the lung cancer, and the responses are there. So this happens in patients where we have really good liquid biopsy tissues. Now, this is another patient. This is a very interesting case. Another elderly, so elderly female. She's a known case of squamous cell CA esophagus, and she had that single lung lesion which I showed you previously. That single lung lesion was there. So the single lung lesion was there. This looked like a primary lung cancer. There is no uptake in the esophagus, so we really didn't know. Patient tried to undergo a conventional biopsy and land up with hemothorax. They didn't want to undergo another biopsy, and then her liquid biopsy was done, and again it was found to be positive for malignancy based on some IHC expressions. So this we understood that yes, the patient is again having a malignancy. Now, when we have a lot of tissue available or on liquid biopsy, a lot of circulating tumor cells, you can actually do all these tests. The napsin A and TTF1, these two are negative, so probably classified that this is not a new adenocarcinoma lung, and this is the old malignancy which has come back with metastasis. So this is there. So this is coming up again in a very big way. Tissue biopsy, yes, it is the gold standard, as we all say. But sooner more than later, we are going to have liquid biopsy replacing all these new, the old modalities. Now, talking about how does liquid biopsy help in these targets and survival? So when we pick up a liquid biopsy and a tissue biopsy, we are picking up more mutations. These mutations help us in identify those patients which can go away with chemotherapy. For example, in this slide, an EGFR positive patient, if earlier we used to only give chemotherapy where the maximum survival was 6 to 10 months, and with EGFR we started looking at a couple of years survival. You can see those two graphs separate right at the first 2 months, and the separation stays up till 2 years. So how does mutational treatment change? The lung cancer survival of stage 4, where we were talking about 6 to 8 months, now we are talking about 2 years, 1 year, 2 years. The newer drugs now, after gefitinib, osimertinib came in, and then we are again surprised with the new survival. So first time in our lives, in our practice, we are looking at 3-year survival in stage 4 lung cancers, where the quality of life was maintained, and the patient is doing is just taking a tablet every day of his life, just like treating BP or sugar or diabetes, and the patient is comfortable and leading a good quality life. All these are stage 4 patients whom you don't have to give chemotherapy. Only a oral TKI tablet is going to give you a response. So that is how liquid biopsy and tissue biopsies are changing. The molecular diagnosis is changing. Immunotherapy added to this entire story, and now with immunotherapy coming in the way, I'm not going to talk in detail about what are immunotherapy drugs and all those things beyond the purview of today's talk. But again, immunotherapy, now we are talking about 5-year survivals. So this was when we were in our residency days, we had 6 months survival, and now we are talking about 5 and 7 years survival in a stage 4 lung cancer. This tremendous achievement of molecular diagnosis, tissue diagnosis, liquid biopsy, and this is, we are going to just grow on this. We are going to hopefully one day this just turns, the lung cancer just turns out to be a chronic disease where patient is going to live his God-given life. How do we use liquid biopsies? Again, there is in refractory cancers, like I put up earlier, you do a tumor-based analysis on blood, and then you can try to look out those many targets and try to talk about what are the targets and what are the drugs which are available, and try to give good responses in refractory cancers. This is a new thing that is going to come up. We had published this data. This is about early diagnosis. So this was something called CTAC, circulating tumor cells, and a rise in circulating tumor cells in patients showed that there is a higher risk of cancer. So this can be used as a screening test. This is obviously in early data. This is early phase, still not used in written practice, but this is the reason for showing this is what the future is. So we are going to diagnose lung cancers based on liquid biopsy in the next couple of years. We are going to talk about molecular targets of liquid biopsy in the next couple of years. And sooner more than later, again, we are going to use the tissue biopsy or the liquid biopsy as screening methods to pick up cancers earlier. So this is what we are. So all those who are interested, this is a wonderful publication which had come here, and which really tells us, are we looking only at the tip of the iceberg? Whatever we are doing today, we have already achieved so much in liquid biopsy. We have looked at so many cases. We have looked at how it is changing the survivals from 6 months, the newer drugs to 5 years and 6 years now. But are we looking at the tip of the iceberg? And this is a fact. This is a paper which every one of us should be reading. If you look at the blue boxes are what we are doing today. The orange boxes are which are coming up, the dynamic applications, and white boxes are which need validation. So liquid biopsy, there are a lot of indications, and this is what we are going to have in the next. We can't go away from liquid biopsy. We can't run. If we are in the center, we are doing tissue biopsy. We have to think about how we can get liquid biopsies, how we can incorporate it in today's practice, because sooner it's going to be that liquid biopsy is going to be the first method of choice, and that is what we want to do. So points to ponder, the last couple of slides. See, cancer diagnosis is easy, important in saving lives. So when we talk about diagnosis, we should not be delaying due to various reasons. We need earlier the diagnosis, earlier the molecular markers, faster we treat the patients, and early decisions and planned actions obviously result in much more survivable. That is where liquid biopsy plays a bigger role in getting the reports earlier. And genetics is the most important weapon. There is no second thought about that. Genetics is the important weapon in fulfilling the goal of personalized medicine, where we are picking up the right dose of the right drug for the right indication for the right patient at the right time. This is what we are achieving today, and this is what how we are going to practice oncology in the future. So take-home messages: liquid biopsy. It is time we accept this and incorporate in today's practice. If we are at a center where we don't have liquid biopsy, it is now high time to understand how we can collaborate with centers who are doing liquid biopsies and how we can get it in our place. Combined approach, as all the guidelines are coming up with, just doing a tissue is no longer sufficient. All the guidelines are coming up with a concurrent combined approach where you do tissue and plasma together. Both are absolutely comparable as regards the diagnosis and the yield. And obviously, if you combine both as seen, you will going to get much more mutations and much better survival. So chemotherapy, again, coming back to that old slide, chemotherapy survival was 6 to 10 months. And if you are picking up more mutations, the survival goes up till 3 to 5 years. Upfront molecular diagnosis is the rule now. This is the new treatment paradigm where you're going to talk about molecular diagnosis and choose the right drug upfront without there is no blind starting of chemotherapy anymore, because there'll be a huge chunk of patients, almost 40 to 50% of patients, where some molecular target is going to come. And these patients, even in stage 4, will not require chemotherapy upfront. There is in fact some data where if you give chemotherapy through this molecular targeted patients, they might do a little more harm. So you can't escape for molecular diagnosis, and you need to have it upfront. You can't just blindly go on advising chemotherapy to everyone. And the most important is that we are practicing at so many centers we are looking at lung cancer patients, it's important for us to come on a common platform like CCI. We generate our own data, collaborate our own data, and make our own guidelines to understand how we can use liquid biopsy, how we can use tissue diagnosis, how we can use complementary diagnosis in today's practice. So that is about liquid biopsy and lung cancer. Thank you so much for the opportunity. And we would go on back to the moderator to take out to the panel discussion. Thank you so much, everyone.
Uh, Hi, everyone. Now, welcome to the panel discussion. Wonderful lectures by two of our eminent speakers. We learned a lot from them. And I think now we move on to the panel discussion. My first question to Dr. Amit is now, whatever data you have shown to us, now, what will be your advice to the pulmonologist who is working in India in the real world? So, what are the specific indications in which he should be actually sending a sample for liquid biopsy? Can you please enumerate them? Dr. Amit.
When we talk, yeah, you can hear me, right? So when we talk about lung cancer, specifically, and we are talking about liquid biopsy in non-small cell. In small cell, the data is not so strong enough. There is still data coming up, but right now, most of the indications are in non-small cell. So if you have a diagnosis of non-small cell, all the guidelines maintain that you can send a liquid biopsy and a tissue biopsy together because you want to pick up more mutations on day one itself. And as I've shown in my slide, if you pick up more mutations as compared to chemotherapy, the more targeted therapy you give, the more chances you're going to live up till 5 years. Now, if we are at a center where we don't have liquid biopsy, obviously the tissue, it's important for us to understand that, okay, on a tissue, we do the molecular markers, but it is no longer sufficient for us to say that this is just a lung adenocarcinoma or a lung squamous cell. For adenocarcinoma, the guidelines maintain that there are 12 markers to be done in addition to immunotherapy, and that should be done. That is even a medical requirement today. That should be done in every patient. Because if you look at earlier, we never used to do because the treatments were very costly. But now, if you look at EGFR treatment, or for example, if Gefitinib, there are so many generics available where the monthly cost is only 5,000. So, if you are not doing a molecular diagnosis and you are missing an EGFR mutation and you are exposing the patient to chemotherapy, you are not only causing obviously harm, but you are also causing. So everyone should think about how we want to incorporate molecular diagnosis on day one of diagnosis.
Hello.
Can you hear
Hello.
me? Yeah,
Yeah.
Yeah.
So you heard my, was I offline?
Yeah, for a short while.
Okay.
I think.
So basically, as I said, so for EGFR, it's the cost is no longer an issue. The treatment drugs are available at a very low cost, maybe 5 or 6,000 per month. So you have to do a molecular diagnosis on day one. There is no escape from that. A simple histopathological diagnosis is insufficient, and a detailed IHC and a molecular diagnosis is must for treatment as of today. So everyone should do for non-small cells
Amit.
on day one.
Hello. Hello. Your audibility is a problem, I think. The technical team, please.
Can you hear me? Because I can
Yeah.
hear.
Yes, yes.
Yeah. Yeah.
My network.
Yes, sir.
Okay. 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 Just let me change the network. Just give me a minute. Just 1 minute. Sorry for that.
till Dr. Jain comes in, let me just elaborate on what I spoke. So liquid biopsy again. So if we are going to pick up more mutations when we are talking about solid and liquid biopsy combined, so we don't want to miss those mutations. So if you are at a center where you don't have a liquid biopsy, try to collaborate because it's been done all over the country at all major centers. So it's not that it is something of the past or we are just talking theoretically. The first paper, molecular paper, which I published was in 2013. So it's been there for the last 10 years, these molecular tests. So it's important that we collaborate. We can't just go away from that anymore.
I think collaboration makes a lot of sense, and I think most of us can send a sample and get it done. So I think should not be a problem for majority of us. Hello.
Absolutely, sir. So
Right.
there are thousands of labs which are doing liquid biopsies available in all parts of the country. The maximum time for a sample to grow from one point to other is not more than 24 hours. So if you have a sample, anyone can do it for you. That's
Yes, agreed. Thank you, Dr. Amit. Now we move on to the next question. We'll have it from Dr. Tejas Shah. Can you just elaborate about the sensitivity and specificity of liquid biopsy, especially in terms of lung cancer?
Sure,
This is a
sir.
question from the audience.
Right. So the sensitivity and specificity of the liquid biopsy will, affect as to what is the endpoint application, whether you are doing from CTCs, whether it's a ctDNA or total nucleic acid or EVs. But as Dr. Amit sir's presentation said, that there are really good publications coming in which have shown concordance sensitivity specificity of more than 90%. And yes, that's the reason the momentum for liquid biopsy has gained up.
Can I just add to that?
Yeah.
Yeah.
Sure,
So
sir.
we are still discussing about how is liquid biopsy good enough as compared to solid tumor even today in our country. Because the simple thing is in 2000, the first liquid biopsy for EGFR was approved by US FDA in February 2017. So
Okay.
US FDA had looked at more than almost 15,000 samples and showed that liquid biopsy is at par with the tissue biopsy and approved in February 2017. It's not a new data. It's almost 6-7 years back. Just another thing that I would like it, if you look at EGFR on the urine sample in a lung cancer patient, the specificity is around 40 to 50%. The sensitivity is around 70 to 80%. That's on a urine sample. So now we are doing samples. We don't want to even prick the patient. We are trying to. The research is going on so that you can find it on the urine also, even the T70, 90Ms on all the bad mutations.
But is it for the real world now? Is it for the real world?
It would come in the real world. Right now the blood is available, but the only I want to say is that is what is it at par? Obviously it is par. We're looking one step forward and we're trying to prick the urine now. So it's like that. So that is where we are as of liquid biopsy today.
That's interesting. But Dr. Amit, what are the limitations of liquid biopsy? What are the limitations we're looking at?
Yeah. So the limitations is the basic thing is it should be a metastatic disease so that you can have a holistic picture. In early stage, say for stage 1 and stage 2, we know the liquid biopsies are not so good to pick up because if there is no tumor spill or there is a very less tumor spill. Now there is concept that tumor spill occurs even in stage 1. So it's not like stage 1 is, we used to talk about basement membranes and basement membrane intact, then it won't go into the blood. So that is stage 1, but that doesn't occur. There are mRNA signatures which can be picked up, but that is still in the screening part or early cancer part. It is still in research phase. So if you have a stage 4 disease, you are confident with the liquid biopsy. If you don't have a stage 4 disease, then you might have a little hiccups doing a liquid biopsy. So that is, I guess, the only limitation from now.
Yeah. I think, thank you, Dr. Amit. Now we'll move on to our pulmonologist, Dr. Anil. For you, I have a question with you. If you have a patient of suspected lung nodule whose biopsy has come negative and the patient has refused to do another biopsy, what would be your next step in your clinical practice?
Sir, if the patient had a lung nodule and the initial biopsy was negative, certainly, as you rightly pointed out, it would be really difficult for me to convince him again for a repeat biopsy. That's always a very difficult task in the Indian scenario where cost is also a factor. So
I
in
think
such
that's
kind
a
of a
common
patient,
scenario for many of us. That's a common
exactly,
scenario for many of us. Yeah.
yeah. So in such a scenario where the getting the acquisition of the tissue becomes very important and I don't have support from the patient, my first take would be I would counsel the patient once again and tell him about doing the repeat biopsy. If he still doesn't agree, maybe I would go for a what you call a PET scan, try to show him if there are any mets or anything and find out if there are some bigger lesions, and we can go for a repeat biopsy. And if still that is not possible and not able to convince, certainly I would give him a chance and tell him about the newer modalities such as the liquid biopsy, which we have been discussing right now, because it being a non-invasive procedure and comparatively the sensitivity and the specificity is being high, I would certainly give a chance and tell him that liquid biopsy is the future and we certainly can go for it.
What's your take about this, Dr. Tejas? What's how you would go for it, and what would be your suggestion for it?
Yes, so as Dr. Anil sir rightly said, if it's not possible for that particular patient, liquid biopsy will surely help out. And even in my presentation, I said something is better than nothing. So, liquid biopsies, isolation of CTCs or ctDNA analysis will give some kind of a mutational, highlight for that particular patient to take ahead for the treatment.
Thank you. Now, the next question is for Dr. Shilpi Doshi. There's a question for you is that as a histopathologist, do you see liquid biopsy as a potential threat for your job or your practice? Do you think that liquid biopsy would gradually replace conventional biopsy, or they will be working hand in hand and both will be equally important? What's your take as a histopathologist? I know our speakers are totally for liquid biopsy, but I think I need the word from the histopathologist who is working in the real world. And what is her take from this whole message which I'm trying to give to the audience?
Thank you, sir. It's a very good question. Actually, histopathology or tissue biopsy is not replaceable, because to diagnosing the tumor, first is the histopathological diagnosis. First, you have to diagnose which type of tumor it is. It is small cell or non-small cell. So first, you have to for making the diagnosis, you have to take the tissue. So if it is non-small cell, then you can go for further molecular testing on liquid biopsy. But to diagnose the tumor, first you have to take the tissue. So tissue biopsy, I think, it can never be replaceable. And it can liquid biopsy. And sometimes tumors are poorly differentiated on this histo also. So for IHC, then you have to apply the IHC, that it is a squamous cell, non-small cell, or a small cell, or sometimes lymphoma. In lymphoma cases, you have to take the tissue only. And sometimes lymphoma diagnosis is not on the core biopsy. We have to get the full excision biopsy of lymphoma. So in non-small cell carcinoma, you can definitely say liquid biopsy, but other tumors other than non-small cell lymphoma or carcinoids tumor, neuroendocrine, so first you have to make the diagnosis. So I can definitely say I have no threat for
You are
this.
still to stay.
Yes.
Yeah. So thank you. That's a very important message that yes, at least at this stage, the histopathology is still very important, and liquid biopsy is definitely coming in up in a very big way. But we have to see how it goes from here. It has some indications at this point of time. Maybe the indications would increase in future, but still at present, histopathology is still very important. Histopathology is important. We need to take a tissue biopsy, send it to the histopathologist, and definitely liquid biopsy will help in its own role, and it can help us to make a better management of the patient. So I think now we move on for the next question. This is to Dr. Moitreyee. Again, this is one important thing which we all see in our practice is that if you have a patient with a pleural effusion with a negative cytology, how you move from there? If a patient comes with a pleural effusion, you get to take a pleural fluid sample, it is negative. And you have taken twice, you have taken pleural fluid sample, both are negative. Then how you move on from there? You have a strong suspicion of malignancy. The patient is something around 75-year-old, old smoker, and you have a large pleural effusion, which is hemorrhagic. and how you go ahead from there, how you do what you do. So
Thank you
what will
very
be
much,
your
sir.
next step?
So the next step in a patient with a highly suspicious effusion would be a thoracoscopy. That would give that
Okay.
being that is invasive, but nonetheless provides a direct visualization of the pleura and provides a lot of important information regarding the pleural space, and also provides in real-time view a tissue, a substantial amount of tissue for biopsy. And the best part is that it can be done under local anesthesia and sedation. So most older or elderly patients are not contraindicated for the procedure. So my next step would be to go for a thoracoscopic biopsy. That is what we do in our clinical practice at present.
Yes. Yeah. Do you think that liquid biopsy will have some role in this situation? Say, for example, the patient refuses for a thoracoscopy or is a relative contraindication for thoracoscopy, then would you consider for a liquid biopsy, or you will not?
Yes, sir. Yes, sir. And, because the pleural space, the pleural effusion, if it is malignant, will have a lot of tissues which can give us information. And it being very minimally invasive and highly specific and sensitive, I think it is very promising if we send the sample for a liquid biopsy. Yes, that we can definitely, we should definitely think about that more in the near future, because thoracoscopy, although less invasive, it carries enough morbidity and requires hospital stay with an IC intercostal drainage. So if we can avoid all that and get the necessary information faster with minimum invasion, I think that would be very, very advantageous, both for the patient as well as for the caregiver.
No, I think, yeah, I understand that. Yes, till now we have been doing thoracoscopic biopsy, which still I think is important. But then I think gradually liquid biopsy may gradually come in, and we may start doing it more often, and then we have more data about it, at least from the pulmonology perspective. And then we may gradually shift our practice. Let's see how it goes from here. So I think that would be a real nice explanation to all the audience. I would like to know from Dr. Amit, what is your take about a patient with a pleural fluid negative cytology in this particular scenario? If we do a liquid biopsy, what is the sensitivity and specificity of a in the for the pleural fluid as far as the malignancy is concerned?
If you're looking at, so if you have a pleural fluid only a cytology negative, usually what we practice at Pune Hospital is you drain off the whatever fluid is there, either USG guided or you put a ICD. If you can collect at least a liter plus of fluid, that is good enough to make a good cell block and get all the diagnosis that you need. So
but there are situations when we don't get a positive cytology. There are situations, and currently we are going for a thoracoscopic sample. However, as you said that yes, we take a larger sample, we can get a histopathology, cytology report positive.
So if we get a cell,
sorry.
Yeah, so if you can get a cell block, you will get all the answers. Where does a liquid biopsy play? A liquid biopsy, as I said, if you're doing it on, if it's a stage 4 disease, obviously, and it's on a blood, then the sensitivity and specificity is pretty high. You can diagnose malignancy, you can pick up the mutations. As far as pleural fluid is considered, there is data where if you even do EGFR mutation on the pleural fluid, the sensitivity specificity is around 70 to 80%. It's not as like in liquid biopsy, it is 100%, obviously almost 98 to 100%. If you're doing it on a blood, but in the pleural fluid also you can pick up an odd EGFR in 70% of the patients. But again, as I said, it's preferable if you have a cytology negative and a PET scan which is suggestive that it is malignancy, it is spread over. More often than not, you're going to get a liquid biopsy positive, and you're going to get answers on the liquid biopsy. A plasma flow approach, which the International Study for Lung Cancer they have suggested. A plasma flow.
I'm asking you, should we send both pleural fluid as well as blood for getting an answer, or only blood sample should be good enough? Are any studies suggesting that we should send both? It improves the sensitivity or specificity?
No, sir. Blood. As of today, the data we can get all the good data, whatever you want from the blood.
Blood. So blood is enough. So okay, that's really nice. And now again, again when we're discussing about pleural fluids. So I'm asking, is there any data about diagnosis of TB in with the pleural fluid, with the pleural infusion? Is it can a liquid biopsy help in making a diagnosis of TB, or no? It's still a long way to go. In pleural fluid, I'm talking about. That's the place which we are always having a problem. I know there's not much of data, but as far as whatever you have been gathering a data, and you know better than us, is there any data coming up regarding tuberculosis, Dr.
Uh,
Tejas?
yeah. So yes, we have been doing NGS based technology for pleural fluid also. Like Gene Expert doesn't help. The only reason is when we
Yeah.
add that particular amount of sample to the cartridge, the
Mhm.
contamination inhibits the CBRAT procedure, the in-house or
Mhm.
inbuilt PCR procedure. But what happens in the NGS is we do maximum weight bench outside the machine, and we try to eliminate all the PCR inhibitors and just put the TB, Mycobacterium tubi positive DNA in that particular machine, that is NGS, and hence we can even process the pleural fluid based sample type for NGS and giving us good sensitivity specificity.
Okay. So you have a reasonable result. What's the
Uh,
sensitivity and specificity? We don't have much of data in our journals. So want to know from
right,
you
but
for
it
TB, what's the
uh,
data?
so off lately in last 2 to 3 years, people have started focusing on TB and NGS panel. Okay, so we don't have that
Mm.
sufficient data, but as a reflex
Mm.
test, we always go back. If the sample type is really something different, we always go for microbiological assays as well, or basic culture, and then we release the report. So yes, it's worked parallelly to increase the sensitivity specificity towards the machine. But
Okay.
when we talk about sputum bal, then we don't go for any reflex test or orthogonal testing. We directly release the report.
Mhm. Okay. Thank you. I think we move on to our next question. This is to Dr. Anil. In an elderly heavy smoker with about 15 kg weight loss and is all labs test negative, including a chest and abdomen CT scan, what will be your next step to establish the diagnosis? Dr. Anil, please.
Good one, sir. I mean, this is one scenario, always is a tough one to take a call right now. The elderly patient, as you said, all the lab tests are negative and he has lost 2 kilos of weight. First
And
thing
he's a
is,
heavy
I would like
smoker,
to,
strong suspicion of malignancy. Yeah.
yeah. The first thing is that I would like to put up a diagnostic algorithm here. I will certainly
Mhm.
think in terms of like, is it an infective process going on or is it a non-infectious process going on?
Mhm.
In terms of infectious process, I would like to re-verify my diagnosis, rethink my diagnosis, take a proper history, do a proper clinical examination once again. And I always believe in that as every criminal leaves a clue. So similarly, every disease leaves its own clue. So a proper clinical approach for infectious diseases certainly will clinch a diagnosis. And while coming to the non-infectious part, as you said, it could be dietary or it could be a malignancy kind of a thing. Certainly, I would do a fresh workup once again. Since, like as you said, most of the tests have been negative, I would certainly run a PET scan once again and do some other molecular workups. This
We
is
have
the
not done a
scenario
PET
where
scan yet, so maybe we can do a PET scan. Yeah, I agree.
okay, so a PET scan certainly, as you said, even we can pick up some minute points in that. Sometimes, very
Mhm.
rarely, there may be some FDVG avid nodules or some other nodules maybe which are not picked up properly. In these
Mhm.
scenarios, I would certainly say the newer molecular tests, the liquid biopsies, and all they are here to stay, and these will certainly help us, sir. So I would
Mhm.
say go with a proper clinical approach, have your own diagnostic algorithm. Certainly
Mhm.
believe in the newer modalities and try to utilize them to your 100% potential and get the diagnosis.
Dr. Amit, would you like to add anything to this?
Amit sir, I believe you are on mute, sir.
Sorry. So
Sorry.
what we are doing right now, see, when we have a suspicious PET scan, so if you look at practice, say 15 years back, we are doing only FNACs, and then we were taking that, oh, the tissue is not sufficient, and then we slowly graduated to newer techniques of biopsy and trying to get more and more tissue so that we can answer all the questions on the tissue. I think what Dr. Shilpi Doshi also said. So we are going back to the old thing. Dr. Abhyankar sir would agree with me. We have treated a lot of many patients where the getting the tissue was so difficult. So we have done EBUS FNACs, got a FNAC tissue, got it said that yes, it is malignant, and the rest all the answers, including there are labs who are doing that. Even the IHCs, the molecular markers, everything we have done it on the liquid biopsy. So from FNAC to biopsy, now we are probably going back to FNAC. A histological diagnosis, as the histopathologist said, the histological diagnosis is must, but we don't want a lot of tissue. We are FNACs, we are happy with the FNAC. So if something is picked up on a PET in a case that you said just now, a simple, if you can get an FNAC from somewhere, molecular would probably give you rest of the answers.
Okay. Thank you. I think when we move to the next question to Dr. Shilpi, when would be a situation when a histopathologist asks for a liquid biopsy? Is there any situation you have faced in your
Yes, sir.
practice?
Sir, we are facing the problems. Actually, when we get the biopsy, sometimes in the tumors, especially squamous cell carcinoma, there are a lot of necrosis. So we get 6 cores or 7 cores, but out of these 7 cores or 6 cores, 4 are necrotic, and only 2 we get the adequate tissue. Then we have to, for the applying of IHC and for this molecular testing, PDL1, we require more tissue. So then we have to take these, that we have to first apply the molecular marker first or the IHC first. So if we are sure on the our histopathology that is it is squamous or adeno, then we skip adeno and squamous and directly go to the this genetic testing. So in these and then sometimes there is metastatic tumors and some poorly differentiated tumor. When we our most of the tissue exhaust in the these IHC samples, then we definitely go for the liquid biopsies for these and sometimes multiple site metastases are there, so we can't take the take tissue from the multiple sites. Then definitely liquid biopsy then can definitely help.
Thank you. That's something interesting. A perspective from a histopathologist. So both the things are required. Both histopathology and liquid biopsy are still staying there. Now I move on to the next question. This is for our...
Sorry to interrupt, sir. Just let me add to that. So today, histopathology in India is still graduating to the liquid biopsy. If you talk to in any major center anywhere in the world who's doing cancer, the answer to that question would be a diagnosis. For every patient, along with the tissue biopsy, the concurrent approach is done at almost every major center all over the world. So that is the correct technical answer for that is we should do it in every patient. In India, because of the lack of facilities, we are not doing it in every patient.
I think lack of facility, cost issue, I think these two are major concerns for all of us.
And sir, one more thing, sir. The turnaround time of these molecular testing on tissue is actually quite long. And I definitely face a problem. This that when will we get the report? When we'll get the mostly 15 days, minimum 15 days time to get the molecular typing on these tissue biopsy. So in these,
we'll ask this question to Dr. Tejas. I think he'll be the right person to give the answer. So what is the turnaround time for liquid biopsy? And another question to the same, and what is the cost of liquid biopsy currently in Indian scenario?
So practically it depends, so the histopathologist doctor rightly highlighted it does take 2 to 3 weeks, but it totally depends upon, so small panels like, single gene testing of AGFR, KRAS, NRAS, if doctor wants to do for any exclusionary testing, it won't go for more than 2 to 3 days, very frankly, on digital PCR. But the larger panels of, 12 gene, 50 gene, 500 gene panel, it usually takes 2 to 3 weeks because, accumulating that sample size and putting it on NGS is really a tough task too. So average time for NGS is 2 to 3 weeks, and for digital PCR it will come for around 2 to 3 days only. So that's one thing. Parallelly, for commercials, it vary from few thousands up to lakhs, depending upon the endpoint application, whether you are planning for single gene. So single gene won't cost more than 4 to 5,000. But yeah, if you're going for a larger panel of 5,500 gene, it might go for a few thousands as well. But then you get, again, the word terminology I used was genomic only, but you get a comprehensive kind of a overview when any oncophysician is treating that kind of a person.
So you think that yes, it is practically doable, and cost wise, what do you say? What is the cost approximately? If
Let
you
me
look at
just add,
our
let me,
optimum cost,
Yeah.
I would put
yeah.
it that
So
way.
let me just add to that, sir. So when you're looking at molecular diagnosis, so if I'm going to do only a single, it depends. The cost depends upon how many genes you're doing. So if you're doing
But
only
then, can we optimize a more or less rough cost? I know that there is a
yes,
lot of
so I'll,
variation
I'll,
there.
I'll I'll just come to that. So if you're doing a single molecular gene, for example, you're just doing EGFR, the turnaround time is only 3 days and the cost is 5,000. If you're doing the recommended NCCN 12 gene the 12 mutation panel, which is recommended for a non-small cell lung cancer, the estimated time is around just 8 to 10 days and the cost is somewhere around 20,000. In
Okay.
refractory cases, now when we are talking about cases who have already taken treatment, have taken refractory, the high-end molecular markers where we are running almost 20,000 genes and the molecular DNAs and mRNAs, they can go up till 1.5 to 2 lakhs. So
Okay.
that is how it is. So, but that is for high-end. For a routine practice,
20,000.
liquid biopsy, you can get an answer
Yeah.
for 20-25,000.
22. Thank you. That's important. I think we want to give a message to the audience. That's not so expensive. What people used to think before is still affordable, and it can give us a lot of answers and help us to treat the patient better. I think that's the message we
Right.
wanted to give. Another question to Dr. Tejas. Two things which comes to my mind in real world clinical practice when we have a problem. In case of suspected occult malignancy, again, we have a strong suspicion of malignancy, we are not able to figure out where is it. Can liquid biopsy help, and to what extent?
Uh, so as I told, the liquid biopsy relies completely on ctDNA and cannot detect on DNA markers if they are not present is one thing. No doubt, yes, somewhere we can work with liquid biopsies in occult malignancies. The results are very preliminary, but yeah, in my own practical lab, we had identified two cases. A high risk clonal hematopoietic CH, is frequently incidental in patients with solid tumors and undergoing cfDNA. So in that case, it was idiopathic, and we could identify when that cell-free DNA was sequenced for high-end comprehensive panel. So that's one case we had came across, and second case where on the other front, the solid tumors are associated with BRM, brain metastasis. So or melanoma or clear cell renal carcinoma, and they are devoid of any molecular marker. So when we get a CTCs or cell-free or circulating DNAs, that surely help us to identify any occult malignancies using
Okay,
liquid
thank you.
biopsies, no doubt. Yeah.
Thank you. I think that's an important message. Sometimes it can help. Another
Yes.
important thing which I want to ask from Dr. Amit. Now, lung cancer screening, we have been listening about it for last more than 2-3 decades. We have not yet, like at least for real world situation in India, though in abroad now people have started talking about low dose CT scans and all that, but it's not practically doable in our country. So, do you think in future, if not now, would liquid biopsy may have some place in lung cancer screening? Do you think any place is expected, or no? It's not. What's your take, Dr. Amit?
Absolutely. So the last paper which I presented, our own data, which we presented in the Cancer Research International Journal. So there is something. There are certain molecular markers which will tell you the risk of a person having current cancer or the cancer risk in the next 1 year. So this is in research purpose, but this data should mature in the next 1 or 2 years. So probably in the next 1.5 year, say by 2025, we are definitely would have liquid biopsy screening test to screen for not only lung cancer, for all the cancers. A word about occult. So this is going to be a fact. There are tests. There are already publications. There are publications from our country. Abroad, there are already multiple publications. But I am a part of that publication which I showed in my presentation, and this is going to come up in the next 1.5 year as the data matures. A word about occult malignancy. So I'd just like to highlight 2 points. The turnaround time for the diagnosis depends upon which labs you send to. Now there are labs which have a very few amount of samples. The lesser the sample, so it's not a very busy lab, then that lab might take 25-30 days, even 4 to 6 weeks for the samples to come. But for example, if it's a very busy lab, so for example, my the fastest turnaround time in a country for EGFR is 1 day at Gangaram in Delhi. So because they land up with almost 70 or 80 samples per day, so the turnaround time for EGFR is just 24 hours, and they have the report the next day. So that is happening in our country. So the entire thing depends upon what lab you send to and how much is the load of the lab, the
That's
turnaround time. The third
that's
thing,
interesting.
the third thing I would like to highlight. One thing is about occult malignancies. In India, we don't have liquid biopsy matured enough to answer those questions. But there are a couple of liquid biopsies which are abroad, which are available abroad, which are now marketed in India. There is something called as Garden 360 and Tempest. So what they look at is every cancer has a specific mRNA signature. So they will pick up. So if you do a liquid biopsy and you can identify a specific mRNA signature in an occult primary, you can tell that this is, say, a carcinoma of unknown primary, probably originating from the pancreas or probably from the lung. So there are mRNA signatures. So, and these are well validated tests abroad. You validated by US FDA. So our labs are maturing to that data. As I said, the first liquid biopsy was approved in US in 2017, and we are still struggling with data, and we are generating data in our country. But for occult biopsy, these tests are available. So in our country, it is available. The turnaround time for the sending the sample to US and getting the report back is 15 days only.
That's useful. I think previously a lot of people used to send the sample abroad, and now we are able to do it in India. I think that has changed the scenario. Things are easily accessible and available. So I think that will make a lot of change in our practice. I think that's important for us. Another important question to Dr. Tejas. Sorry, I'm asking both mainly to Dr. Tejas and Dr. Amit because you are the experts. We are learning from you. I'm learning from you guys. So, and Dr. Tejas, what are the what can a liquid biopsy test not detect? Because that's important. We have been discussing about what it can detect. What are the things,
Right.
especially in malignancies I'm talking about, which they are not useful at all? Maybe you can tabulate and tell us so that people know that don't do liquid biopsy in this scenario.
Yes. So previously I said, liquid biopsy is totally dependent on the CTCs, circulating tumor cells, circulating
Uh,
tumor DNA, circulating
uh,
TNA, total nucleic acids, and EVs, right?
uh,
So if all these four, DNA or RNA markers are not there in the particular, liquid biopsy sample, be it be CSF, blood, or saliva, uh, then we cannot bound to do that. This is one thing. Okay. So, and the second importantly, even though we get certain amount of CTCs or DNA RNA concentration, the you might not get insight into many tumor properties important for grading and staging of that particular cancer type. So that's the second big advantage I
I
personally
want to
believe.
interrupt you. Becoming too technical. Now, no one knows whether DNA is there in that or not in the sample. So you need
Uh,
to tell us that what you rightly told us that yes, if these things are not there, you will not be able to detect. That's fine. But I
right.
want to be specific that if you are suspecting which type of malignancy, you should not go for liquid biopsy. That's the question. I'm talking about a practical question that when should you not send a liquid biopsy and when should you, as we have discussed a lot about when to send liquid biopsies. I'm asking when
Right.
not to send liquid biopsies.
So right now it's validated only for four kind of cancer, solid tumor cancer types, like be it be lung, NSCLCs, breast, prostate, and colorectal.
Mhm,
Apart from that, multiple other are under validation because of tumor shedding properties of
mhm,
this particular cancer type. So this is one thing we can consider.
mhm,
If it's a malignant kind of a thing, we are bound to get a comprehensive or good yield of CTCs. So yes, if it is that way, we can think about it. If it's very early in the stage, then it's gonna be difficult to find CTCs in the whole volume of the blood in the body, the circulating blood. So that's
mhm,
the third thing I can tell about where it is going to be difficult to offer any liquid biopsies.
mhm. I think I have asked majority of questions. If any of the panelists want to ask any question, please welcome. Any of you want to ask questions to Dr. Amit or you want to discuss something?
Till
Please,
someone
all
else,
the panelists are invited to please ask
let,
any questions if you want.
so let me just comment upon what Dr. Tejas just now said. So liquid biopsy, if it is a non-small cell, so if I have a histopathology, maybe I have an FNAC which says it is non-small cell, the liquid biopsy is indicated. If it is a small cell, we don't do liquid biopsy in small cell. So a simple
Yes.
diagnosis
Agreed.
of non-small is sufficient. Now, where liquid biopsy really falls back, and our data is not that good, is in resistant cases. In upfront, the regular upfront fresh cases, treatment naive cases where we are looking at basic molecular markers, a liquid biopsy usually tells us answers in all the patients. But our labs are mature enough to give in the upfront treatment naive patients. But a typical patient who has taken multiple rounds of, say, chemotherapy or multiple rounds of targeted immunotherapy, and the patient is developing resistance. In those cases, picking up the cause of those resistance and bypassing those, I think that there is where liquid biopsy has to develop a bit so that we can treat our resistant patients a little better who are treatment resistant. That is where liquid biopsy is not really helping us, but probably in the next couple of years, we would mature that data as well.
Any other
Can I
question
ask
from
one
any of our
question?
panelists?
Can I
Yeah,
ask one
please.
question? Sir,
Please.
most of the time when we are performing EBUS, so that time, especially in mediastinal lymphoma cases, we face this problem. Can in lymphoma, most of the time medical oncologist said in lymphoma cases, EBUS has a very little role. And we get enough biopsy, we diagnose that it is a lymphoma tumor. But do you have any results of flow cytometry on this FNAC material? Because we get enough FNAC material in EBUS material, can we perform this flow cytometry? Please.
Dr. Tejas, you want to answer this question?
Yeah, absolutely. We can perform. If we have got the CD markers for that, we can surely go ahead. Only thing is, the gradient to segregate the cells a bit tricky. But yes, nowadays from Beckman Coulter's and BD as well, the panels are available for this kind of EBUS TNBA. So yes, that can be very much done by the FCM flow cytometry analysis.
Okay,
Yeah,
sir.
I want to add something to this. Now, EBUS, now we can have better tissue. It's possible. First thing is we can go for a cryobiopsy from the lymph nodes also. So it gives you much bigger, better tissues. And with EBUS, you can get enough tissue for doing for even for a lymphoma. So it's no longer that it cannot be achieved. We can get a tissue even with the EBUS TB and a needle. We can get tissue as well as cytology both. So I am doing it very often, and I use sometimes use even 19 gauge needle, and through EBUS I am able to get it. And a cryobiopsy from the mediastinal lymph nodes is an established technology now, and that also can give you a very good answer. So it's not that you cannot get enough tissue with the help of EBUS, and this the tissue which we get, we can set it for all molecular testing. So it's practically doable. Yes, sometimes it may be difficult, but with the upcoming cryobiopsy from the mediastinal lymph nodes, this thing also is gradually getting sorted out. So that's possible. It's not that it is not possible now. Though not all centers do cryobiopsy, but it is rapidly coming up.
Yes, sir.
Dr.
Dr.
Sushil,
Abhyang,
can I? Yeah. Can I ask a question to Dr. Amit? Because this is one question which we grapple around all the time. Is it a dead tissue? Is it a dead acid-fast bacillus? Is it a dead tumor versus is it a live tumor or a growing tumor? Can liquid biopsy sort this out?
There are monitoring assays for liquid biopsy available. So monitoring, but obviously a single sample you might not give you an answer, but a paired sample, say a month apart or a 15-day apart, where you find the mutations rising or where you find the circulating tumor cells rising, definitely you can understand it's a live tissue, it's a dead tissue if the disease progression is occurring. NCCN guidelines, which is our oncology Bible, the NCCN guidelines have started incorporating CTC, that is circulating tumor cells, in at least the 4 major cancers now, where they have said that you can monitor your disease if it is increasing or it's coming back on blood biopsy, on liquid biopsies. So yes, it's very, very well doable as of today.
So you have to trend it rather than do it on a single sample.
Exactly. A single, it has to be paired samples that you can get a clear picture of what is going on inside.
Yeah, that's good.
I
Thank
have
you.
a small question.
Yeah, please.
Yeah. What is the role of bronchoalveolar lavage fluid as a sample? Is it superior to, inferior to blood when we go for a liquid biopsy? Is there any
Dr.
role of
Tejas? Yeah.
bronchoscopy?
This is pertaining to more of oncology or TB panel?
More of oncology.
Yeah. So, BAL, very frankly, is not a good sample type when we put it on NGS, because again, it has multiple, secretions which degrade our, or which won't give us a appropriate coverage while we operate an NGS, very frankly. So I don't recommend BAL as such, but yeah, CTCs or liquid biopsy coming from peripheral blood will be an ideal way to give you or me a concrete result with good sensitivity specificity.
Okay, so there will be a lot of other information which will interfere with the gene sequencing.
Yes.
Okay.
Right.
So, but you asked about TB as well. So, is it
Yeah.
better for TB, or it applies the same?
For TB, sputum and BAL are really good, sample types to go for any testing, be it regular microscopy, NGS, or CBNAT as well. So we don't have any issues with that.
Thank you so much.
Thank you. So for TB, it's useful. For malignancies, it's not. That's the bottom line. Thank you.
Right.
I think we go for the last question for today from Dr. Amit. From now in next, say, 2 to 3 years, what do you look as future of liquid biopsy? Where are we heading towards? And I want to have a word from your end that what we look at from now, that what will be the future of liquid biopsy?
What we are
What do you
looking
think?
at, the final aim is to increase survival of oncology patients. So the liquid biopsy, the research is going on only for trying to detect all the patients either before in stage 0 or stage 1 or stage 2. If liquid biopsy matures enough to pick up those early patients, then only we are going to assure that survival. See, whatever stage 4 we have achieved, it is obviously tremendous. From 6 months, we are going down. First, we talked about 2 years and 3 years and then 5 years. But finally, there is a definite limit. It's not gone unlimited as of now. So the only way a liquid biopsy can really come in a big way or help us in the big way is to detect those stage 1 and stage 2 cancers. If our assays mature enough and they are good enough, then we can really make a difference in the survival, like we are doing in, for example, breast cancers. Breast cancers now are being detected pretty early, stage 1, stage 2, and where the curative rates, which were only say around 30 or 40% a decade back, as high as 80% now. So we have to talk about cancer cure in patients, and there is where liquid biopsy is going to help us in the next couple of years, picking it up in stage 1 and stage 2 cancers.
Thank you.
Yeah.
Any questions from any of the panelists?
Can I make a last comment on this, Sushil? Because
yes,
I think
please.
if the mountain doesn't come to Muhammad has to go into the mountain. So if the tissue is not going to come to us, we will reach there. Sushil has EBUS, everybody has EBUS. We can go deeper. People have now cones and beams and all kind of things. So I think one way or the other we will give them enough tissue, one way or the other. And then those issue of circulating tumor cells, if it is not coming into the blood, we will go there and we'll give you enough samples.
We'll give you the issue for that.
Yeah.
Right.
Any comment from any of the panelists?
Nothing at my end.
I think an excellent discussion with all the panelists. Thank you, everyone. Thanks, CCI, for giving us this excellent opportunity. Thanks to all our panelists, Dr. Amit, Dr. Tejas, Dr. Shilpi, Dr. Anil, Dr. Moitreyee, all of us. I think thank you, everyone. And special thanks to Dr. Nitin Abhyankar, sir, for being here with us. And I think I conclude here and we stop our panel discussion now and hope that people have enjoyed it. I enjoyed it thoroughly. I learned a lot from all of you. Thank you.
Thank you so
very
much.
much.
Thank you, Dr. Sushil sir, Dr. Abhyankar sir,
Dr. Sushil.
Amit sir, and all the panelists as well. Thank you.
Thank you.
Thank you so much. It was lovely.
Thank you.